And without further ado, patient-centered care, doing better together, improving cancer care for people with incarceration histories with Dr. Andrea Knittel. All right. Dr. Knittel, welcome. So glad to have you here.
Thank you. I'm happy to be here.
Well, let's find out a little bit more about you. As medical director for carceral, and am I saying that right?
Carceral.
Carceral, thank
Yep.
you. Carceral OB-GYN at UNC. Dr. Knittel runs the OB and GYN clinic services within the state prison system. She is a fellowship director for general OB-GYN research fellows and dedicated mentor. She is the American College of Obstetricians and Gynecologists liaison to the National Commission on Correctional Health Care, and her clinical practice in the state prison system includes coordination of cancer care for her patients. All right. What's something we should know about you from your outside of your very impressive lineup of professional activities?
Yes, we have discussed before. I have a lot of animals at home.
Yeah.
So I have 2 dogs and 3 cats.
Wow.
And I often say that we are at peak animal in our home.
But can one ever really be at peak animal?
Yes, that will be my fun fact for today. You can, in fact, be at peak animal, and it turns out
Gotcha.
it's probably 2 elderly cats and 2 very young dogs.
Oh, boy.
And
Yeah.
it's
Yeah.
a handful, but a lovely
Yeah.
handful.
Good for you.
Yeah.
Good for you. Well, I mentioned poll everywhere. Cancer is the leading cause of mortality among incarcerated persons and people recently released from incarceration. This is a true-false question. So we talked about how to use poll everywhere. While you're putting that in, I'm just going to flash up our ACCME disclosure and our ANCC disclosure, and then we can take a look. And let's give everyone another 10 or 15 seconds to think about this. Again, this is totally anonymous, so put in your best guess in terms of the answer on that, and then Dr. Knittel can talk about that in just a moment. All right, Dr. Knittel, how are they doing?
They are doing well. 95% of you are right on. Cancer is a leading cause of mortality among folks who are currently incarcerated as well as people who've returned to the community. And we'll talk a little bit more about those details as we go.
All right. Well, let's go ahead and advance one more. And doing better together, improving cancer care for people with incarceration histories. Andrea Knittel, MD, PhD, FACOG, and we'll let you take it from there.
Wonderful. Thank you so much.
Thanks.
Welcome, everyone. I'm really excited to talk about this topic today. I am not an oncologist, but as I mentioned in my bio, I spend a lot of time coordinating cancer care for folks who are in my clinics, and I'm excited to share both some of my clinical experiences as well as some of the research that I've done in this area. So I'm going to use a number of terms that may not be familiar to you today. The first is the criminal legal system, and that is really the broad system of laws, policing, the court system, community supervision, so parole and probation, as well as jails and prisons. And I use criminal legal system instead of criminal justice system to reflect that there is not always a tremendous amount of justice in the system, and so criminal legal feels a little bit more accurate to me. I'll also use the term carceral system rather than correctional system or correctional facilities. And that is really to refer to the network of policies, facilities, and individuals that incarcerate and surveil folks in our country. And I use this rather than correctional, again, because there is not a tremendous amount of correcting that happens in those systems. And so you'll hear me refer to carceral facilities, or sometimes custodial officers or carceral officers. I'm also going to talk a little bit today about both jails and prisons, and I'll also just make a note that most of my work is in either jails or prisons and not in immigration detention centers, which are their own sort of special is maybe the best word I can choose, circumstances for folks who are receiving cancer care. So we're going to focus on these other facilities today. jails, which primarily house people who are either awaiting trial or serving short sentences. These facilities are operated by the county, and what that means is that there are a tremendous number of them, and the number of resources and the available resources vary tremendously. So in North Carolina, we have 100 counties. We actually have 97 different county or regional jail facilities. It is notable that in some states, an overcrowded prison system, as well as sometimes an overcrowded immigration detention system, may result in jails accepting contracts to house patients or people with longer sentences who would otherwise be housed in a different facility. I'm also going to talk about prisons today. Generally, we think of prisons as housing people who are serving felony sentences, which are sentences of more than a year. There are separate state and federal facilities and systems. And what is really important about North Carolina, and that I've noted in some states, including North Carolina, jails are actually able to send people with medical needs to serve their jail time in our state prison system, whether they're awaiting trial or serving a short sentence. What this means is that if you, for example, work here at UNC with me and see someone who is in the custody of the North Carolina Department of Adult Corrections, our prison system, that person may or may not actually have been convicted of any crime. They may just be awaiting trial. And if they are a patient who has cancer, they may have been transferred for that higher level of care that is available through the prison system rather than their county jail. I'm also going to use some sort of awkward phrases occasionally to describe folks who are incarcerated. And that is because people are assigned to carceral facilities based on their sex assigned at intake. Usually, sex assigned at intake corresponds with one's sex assigned at birth, irrespective of your gender identity. And what that means is that folks who are in facilities that may be designated as women's facilities include a large number of women, but also transgender men and other people assigned female at birth who have a range of gender expansive identities. And the converse is true of folks who are assigned to men's facilities. They include a large number of men, but also some trans women and other folks assigned male at birth with gender expansive identities. And so mass incarceration directly impacts millions of people, and indirectly impacts even more. So when we look at just who is in a prison or a jail today, right now, we have nearly 2 million individuals. When we expand that and look at individuals who have previously been incarcerated in either a state or a federal prison, we're looking at close to 5 million, nearly 20 million who have ever been convicted of a felony, nearly 80 million with any criminal record. And when we get to the point where we look at immediate family members of individuals who've ever been to prison or jail, we're looking at more than 100 million adults. And so whether this is disclosed to you or not in your clinics, in your practices, these patients are there. And their families are there, and involvement in the criminal legal system results in these collateral consequences that are mentioned here in terms of ways that having a criminal record can affect voting, housing, access to education and employment is complicated and can be really quite long-lasting. We're going to zero in today and focus on individuals who are currently incarcerated or recently have left incarceration. And so when we look at the broad system of folks who are incarcerated in the U.S. today, we see that a little more than half of them are in state prisons, and then a smaller number in local jails. You can also see that an even smaller number, that little tiny but blown out on the far side fraction, shows how many folks are in immigration detention, who are involuntarily committed in mental health institutions, as well as territorial prisons. And what is, I think, most remarkable about this is really its contrast with the slide I'm about to show you. So what I want you to remember from this is that really fewer than half the number of people who are in state prisons are incarcerated in local jails, with local jails being those smaller facilities with fewer resources. Now, I am an OBGYN, and so most of the patients that I am seeing are assigned as female at intake, and of those, about half of them are incarcerated in local jails. And so we see this really different pattern of incarceration between individuals assigned male and those assigned female at intake. And while my initial reaction was, oh, great, all of these women are serving short sentences, they must have shorter involvement in the criminal legal system. But what it actually seems to mean is that individuals may be cycling through the criminal legal system with a series of short engagements and short incarcerations, and that they are primarily in facilities where they don't have access to great healthcare resources. And so, as we'll talk about later on, this has huge implications for screening, diagnosis, treatment, and survivorship in terms of cancer care. And so I would absolutely be remiss if I did not talk about the wildly unequal burden of incarceration across the U.S. There is a massive overrepresentation of minoritized racial and ethnic groups. One's ability to pay cash bail, which is a concept that we don't need to understand in detail today, but the take home is that it means that if you don't have access to resources, to financial resources, you may end up spending time incarcerated pre-trial where someone who did have access to material resources might be able to go home. It's also notable that the majority of people experiencing incarceration, and this includes the majority of individuals who need cancer care during their incarceration, have either a mental health diagnosis or a substance use disorder. The vast majority are parents of minor children and were the primary caregivers of those children prior to their incarceration, and come into the criminal legal system with a history of trauma already, whether that is childhood, physical, emotional, or sexual abuse, or abuse and trauma that occur as adults. And so zooming in a little bit on North Carolina, we have a total of 53 state prisons. Notably, the hurricane last week did involve evacuating a number of facilities in the western part of the state. And I think we all often forget about individuals who are incarcerated in these institutions when we have major natural disasters or man-made events that require sort of movement of individuals across our state. So across those 53 state prison facilities, there are about 30,000 people who are currently incarcerated. We have 6 federal facilities in North Carolina, including a federal facility that is designated as a cancer specialty hospital at Butner. And then, as I mentioned, we have 97 county jail facilities that house about 18,000 people at any given time, although over the course of a year, they actually house many tens of thousands more than that because individuals are cycling through those facilities much more quickly. The images here just show you where those state facilities are located. And then when we compare North Carolina's incarceration rate, which is 639 people per 100,000 residents, we see that we're a little bit below the U.S. average, but it is really important to keep in mind that incarceration in the United States is unique globally. There is no other country that incarcerates people quite like we do. And when you compare our incarceration rates to other countries whose health outcomes we admire or strive to emulate, our incarceration rates are many times higher. So, we're going to switch to a poll everywhere question. And I would love to have you weigh in on whether or not you've taken care of a patient who was recently or currently incarcerated. And these are going to be the choices that you have.
Great. So we've got, and what we'll do, typically we would have gotten rid of this slide and just gone to the poll everywhere slide. But Dr. Knittel, your slides are so beautiful that we elected to keep this slide and then go to the poll everywhere one. So the A will be, we routinely see patients from these. Have you taken care of a patient who is recently or currently incarcerated? Yes, we routinely see patients from these settings in my practice. Yes, we occasionally care for patients from these settings in my practice. Or no, I have not. And now you can go ahead and now we'll give everyone an opportunity to do the A, B, and C that correspond with those, and give everyone 10, 12 seconds to go ahead and fill that out.
Perfect.
Just want to say thank you. I love the way everyone's jumping onto the poll everywhere and
warms
taking
my
care
heart.
of that.
Yes. And I think as we're seeing folks weigh in here, it is, I think your experiences reflect the experiences I've had interacting with healthcare providers across the state, which is that the majority of folks have taken care of folks who were recently or currently incarcerated. And many times that is just an occasional individual who comes in from either a local prison facility or local jail facility. A few of you who see lots of patients who are currently or recently incarcerated. Some of you may be my colleagues working in the state prison system or here at UNC. And then a healthy minority of those of you who either have not taken care of a patient who was recently or currently incarcerated, or didn't know that you were taking care of someone who had recently been incarcerated. So I appreciate this sort of level setting as we move forward. So when we dive into the health disparities that are related to cancer and incarceration, we see that there are a number of cancers that are somewhat more common among individuals who are incarcerated, largely due to a combination of factors. One, that individuals who are incarcerated are less likely to have had access to preventive and screening options that would have detected some of these cancers as pre-malignant lesions, or to actually receive interventions such as HPV vaccination that could have prevented those. And so we see that the most common cancers among individuals who are incarcerated are cervical, colorectal, hepatocellular, lung, and then non-Hodgkin's lymphoma. And you'll note that the majority of those are screening detectable, screening preventable cancers. In addition, cancer is a leading cause of mortality among incarcerated persons and individuals recently released from incarceration. And it is important to recognize that cancer-related mortality is higher among individuals with incarceration histories compared with those without. What we don't have at this point is really detailed information about why this is the case. And so what we surmise is that the combination of healthcare disparities that come into the prison from the community persist there, and then potentially incarceration itself is introducing some additional challenges in accessing care, in screening and diagnosis, and we'll talk a little bit more about that as well. So when someone is incarcerated, there are a number of harms that happen, and each of these, while it may not be directly related to health and cancer care, has downstream effects on accessing really the cancer control continuum. And so we see that folks who are incarcerated, if they were employed prior to their incarceration, they generally lose those jobs. They may lose their housing as well as housing benefits. And they are increasingly reliant on family and social supports for needed resources. So it may be that when they were employed, they were able to have a car, but once the employment is gone, the car is gone, and so you suddenly need family and other social supports to bring you to appointments and help navigate all of those things. We also see that folks have disruptions of their medications and ongoing medical care. Something we'll talk about a little bit later is really the fragmentation of care that happens when folks are in often a variety of facilities, because for many folks, their involvement in the criminal legal system may start in a county jail, and then they may transition to either a different jail, or they may transition into the prison system. At each point, they may or may not have hospital or outpatient visits that use a variety of medical records. And so there is, even in facilities that are able to provide a tremendous amount of care and a high level of care, just being incarcerated almost always is a disruption in whatever care has been ongoing. We also see that folks who are incarcerated are exposed to solitary confinement or quarantine. Particularly in the context of the pandemic, individuals were placed in solitary confinement, sometimes ostensibly for their own protection, although what we also know is that exposure to solitary confinement is associated with an increased risk of death following incarceration. And so these harms that are collateral consequences of what in various instances have been attempts at infection control really do have harms that follow patients as they move through the system and then return to the community. We also see that folks are re-traumatized. So as I mentioned, the vast majority of folks who are incarcerated have experienced trauma in the past. And when they are then subjected to disrespectful language, invasive questioning, unclothed body searches, those things are highly traumatizing, and for individuals who've experienced trauma in the past, re-traumatizing. And I will just mention here also some additional harms that are related to substance use disorders. The prevalence of substance use disorder within the criminal legal system is incredibly high, and that includes among individuals who are needing cancer care. And so when individuals are experiencing unsupervised substance withdrawal, interruptions in their medications for opioid use disorder, that can also complicate their desire, willingness, and comfort with receiving cancer care in that same setting. It also can introduce a tremendous amount of distrust in those systems that I would argue is sort of a healthy distrust, given that other recommended medical care is not being provided. We also see that individuals experience a delay in referral to substance use disorder treatment, largely because these treatments are not available within most jail facilities, and what is available in either jails or prisons is extremely limited. And we see that individuals who are incarcerated have an increased risk of overdose and death by more than 40 times during the first 2 weeks when they leave incarceration. And so whether or not an individual is receiving cancer care or not, if they have a substance use disorder, this is a tremendously heightened risk for mortality that is introduced just with the experience of being in a criminal legal facility or a carceral facility. So now I'm going to transition and talk about two specific challenges to equity, and then I'll offer you a couple of opportunities really to improve cancer equity for folks who are incarcerated. So stigma and discrimination are huge. Many of my patients and research subjects have described incarceration acting like a scarlet letter with healthcare providers and employers and society. When individuals leave criminal legal settings, simply telling a cancer provider, for example, that your last medical records will need to be obtained from a jail involves disclosing something that can be really stigmatizing. Individuals also may have more intense experiences of stigma and discrimination related to intersecting identities. So that can be related to race or ethnicity, class, ability, and in particular, their language, substance use history, and then also pregnancy. What I recommend for individuals who are working in clinics, whether they know that they care for a tremendous amount of people returning to the community after incarceration or currently incarcerated individuals or not, is to really think about whether or not there's a role for screening for incarceration history. There may be, if there are resources in your community, in particular related to addressing the trauma of incarceration. that you may be able to refer patients or clients to. What I do recommend is really only screening for incarceration history once an appropriate response to a positive screen has been identified. And I often joke with my residents and colleagues that I recommend sort of the eyebrow test, which is that if someone tells you that they've been incarcerated and your natural response is for your eyebrows to go up and to feel slightly panicked about what to do next, your clinic is not yet ready to screen for incarceration history. It doesn't mean you can't get there. It's just not quite time to roll it out. And so I encourage you in that process to identify the resources that are available, connect with your local health departments, with your local legal aid, with your favorite social work buddy. I rely on my social work colleagues regularly. And whether you're screening or whether a patient simply volunteers information about a recent incarceration, it is always reasonable to focus on normalizing for the patient that incarceration is a traumatizing experience and that they may need resources to process and deal with that trauma, as well as legal resources in terms of navigating the criminal legal system. And it is always important to just focus as well on the language that we use. It matters tremendously. I avoid really any stigmatizing or essentializing language. I know that I wouldn't want to be identified by a single noun that described what was potentially the worst decision I've ever made in my life. And I feel confident that my patients also don't want to be identified using any of that language. And so just as we try to use person-first language to describe disease conditions, right? We don't describe a patient or client as the breast cancer, or we describe them as a patient with breast cancer or a person with breast cancer. Similarly, a person experiencing incarceration, a returning citizen for someone who is returning to the community after incarceration, a person with a substance use disorder or in recovery or who has returned to use, are all language that everyone can see themselves in that language, and also can see that you're recognizing their humanity first and then identifying whatever criminal legal issues may be affecting their care or their lives. And so the SAMHSA definition for trauma is an event or circumstance experienced as physically or emotionally harmful or life-threatening. And what we know about trauma is that it results in adverse effects on functioning and well-being, and this can be through the life course. So individuals who experience trauma as children are more likely to have physical and emotional adverse effects on their well-being into adulthood. And as I mentioned before, the idea of invasive body searches, demeaning language, and solitary confinement, particularly in the context of cancer care, can be additionally traumatizing. And then we introduce really the separation from family, as well as limited or no support during outpatient treatment, surgery, and inpatient admissions. And so I feel certain that all of you that are providing amazing cancer care across our state help your patients to reach out to and rely upon their social networks to support them through the many challenges that they encounter. And for our patients and clients who are incarcerated, they don't have access to these resources. They may be able to contact family through phone calls, but they're not able to have support people present at their chemo appointments. They're not able to have a family member in the waiting room while they're having surgery. And often they're not even disclosed the dates when those things will be happening. I've had many patients ask whether I could tell their family simply so that their family could pray while they were undergoing some element of care. And that is largely prohibited during incarceration. And so when we're taking care of folks who have experienced trauma, either remote or recent, we want to embrace trauma-informed care. I suspect that many of you are doing elements of this in your practices already. It's most effectively implemented with leadership from patients and clients who've experienced trauma. And it really allows for the explicit recognition and addressing of trauma, both through, as I mentioned, referral for resources for the ongoing effects of trauma, but also even maybe more so than we would with a patient who hadn't experienced trauma, we want to talk about what is happening and what to expect. I think this is a core, all of the friends and loved ones that I have had who've gone through cancer treatment, I think what they appreciated most about their providers was their willingness to talk through what was happening and what to expect. And our patients and clients who experience trauma benefit, I would say, even more from knowing what to expect. It's also critically important to be honest about what you can and cannot affect about the care that you provide. I regularly run into situations where a patient who is navigating cancer care has asked me, can you get me boost? Can you get me a bottom bunk? Can you get me some other element that is going to make my care or my life a little bit easier while I'm going through this experience? And I try to be really brutally honest that I will ask for all the things and I will do everything that I can to get those, but ultimately it may not reside with me, the power to make that ultimate decision. And then, as we do with all patients, really making sure to explain procedures and try to empower patients to ask questions, have time to think about what it is that they want to do. They may need to have additional time built in so that they can go home from the appointment, call a family member, and discuss all of the options that were available to them and presented to them, and then follow up. Whereas a patient who is able to have a family member or a support person there with them may be able to make decisions more efficiently. So we have our next poll everywhere, and I am just seeking some free responses from you all about the ways that your practice helps patients with prior trauma and trauma related to their cancer care. This can certainly be a very stressful time in a lot of folks' lives, and I suspect that you all have great ideas in terms of how to navigate this.
All right, so if you'll go ahead and move it one more slide, and then we'll go ahead and put those up on the screen as we receive those. What are some ways that your practice helps patients with prior trauma and trauma related to their cancer care?
And these can be things that are as simple as checking in with patients when they come in, that, everyone on your team says, "Hey, how are you doing?" Yeah. And so it doesn't have to be a massive intervention that you do. Just I think the little things can really make a huge difference.
All right, so we provide direct care with a behavioralist or therapist. We have behavioral health services offered through our FQHC for these patients. Thank you all so much. We're getting more. Peace, love, expressive art, supportive care rounds.
These are wonderful things.
Care management support. Understanding, empathy, clear explanations, room for questions.
Brilliant. You all could be writing the textbook on trauma-informed care.
Providing information to resources like support groups, asking about their support network. Social worker and RN patient navigators meet with patients to discuss resources and needs. And let's take one more. Supporting patients involves creating a safe, supportive environment that fosters trust.
Yeah, that is really a wonderful thing. That trust word is such a huge piece when our patients have often had their trust broken by many individuals in their lives. Really establishing that trust with their cancer care is really important. So I'm now going to talk us through some specific steps toward cancer equity, and we're going to talk about each of these 4 things, and I'm also going to provide you with some examples that we identified focused on GYN cancers. So the first piece when we think about cancer care related to incarceration, I think the first thing that comes to many people's minds is compassionate release, that individuals who are dying of their cancers should not be dying in facilities. What is challenging about this is that most policies do require some sort of extraordinary or compelling circumstances for compassionate release. And the eligibility requirements are incredibly complicated. I think we all think about, sort of the cancer care guidelines and kind of following, you start in this box and then there are arrows here and then there are a bunch of different places that you can end up. And there is no flow diagram to help folks individualize, are they eligible for compassionate release or how do they navigate these systems? And so there may be specific conditions. Across the U.S., there are age minimums ranging from 55 to 70. And there may be financial requirements, such as the ability for someone to have family and housing support. Some states actually require that individuals absolve the criminal legal system of the requirement to pay for their cancer care and we'll talk about insurance access after incarceration in just a moment. But prior to the expansion of Medicaid, as well as a number of other interventions to increase Medicaid coverage after incarceration, it really is a devastating thing to think about not being able to take compassionate release because you would not be able to pay for your cancer care, and in particular palliative care and other support outside of that facility. Most compassionate release policies also rely on prognostication, which I am certainly preaching to the choir. We are bad at that. And so there are differing requirements by state, and certainly the reliability of prognostication, but then also liability concerns on the part of both physicians and other providers, as well as parole boards and compassionate release boards, really trying to determine whether or not it will politically look okay for an individual to leave the criminal legal system. These really, in many ways, fail to recognize that individuals who are elderly, individuals who are very ill and navigating cancer care are extremely low risk to commit additional crimes once they are home. But politically, it remains a really challenging topic. The other piece that is challenging, I mentioned the both public safety concerns, but then also needs to have financial resources. We know that individuals come into the criminal legal system with differential access to housing, support, and caregivers, and being incarcerated does not improve access to basically any of those things for when you leave. And so seeing individuals really try to navigate that compassionate release system or the compassionate release policies, we see those same disparities playing out. As I mentioned, many of the public safety concerns are also fairly exaggerated in terms of certainly, I don't know that anyone would feel great about saying, oh yes, we're going to return someone who killed a lot of people to your neighborhood. But you might feel a little bit different if instead you knew, okay, yes, that person made some really poor decisions, but that was 30 or 40 years ago, and now they're receiving hospice care, and really, their sentence was not to die without dignity, but rather to, be deprived of liberty during that time. So, kind of navigating these public safety concerns, but also the fact that in the U.S. we really have an incredibly punitive approach to law enforcement and to individuals who, particularly when they are young, commit crimes. The next piece that I'll talk about is really thinking about how to facilitate continuity of care. And that is really addressing this fragmentation that I mentioned earlier. So there are so many points of disruption or potential points of disruption where someone is receiving care in the community. They then are arrested and incarcerated in a jail facility. They may transition between jails and prison facilities. While they're there, they may go to the hospital for care. They may go to outpatient clinics. They may transfer again within facilities. And then when they return to the community, they may or may not be going back to the same community where they started. They may not be going back to the same community where they were hospitalized or where they received outpatient care. And this really does contribute to delayed diagnoses, missed follow-up, as well as exacerbation of stigma and trauma, because individuals are then forced to disclose over and over and over again where their care was, and to try and recount, okay, yes, so in this year I was in this place and I had this biopsy done, and then I was in this place, and really disclosing that scarlet letter can be a major barrier. In terms of ways to try and address this within the clinic, I think is challenging, but not impossible. And so certainly if you know that you have a patient or a client who has become incarcerated, right? They miss an appointment, you call their partner, auntie, grandma, whoever it is that helps them to navigate those things. And that person says, oh, you know what? Actually, so-and-so is in the jail. Absolutely refer those patients for case management services. And also, when your clinic receives a records request from that prison or jail, respond to that immediately. I have even gone so far as to try and call facilities and say, hey, I know my patient who needs X, Y, and Z is in your facility. Can I please have you sign a records release so that I can share and facilitate continuity of care? That is not always successful, but I think is always worth trying. And then when folks are coming home, it is so important to partner with organizations providing reentry services. So that may be transitional living situations. There are many counties that have local reentry councils that offer an array of services for individuals across the state. And then certainly request and then insist upon getting records of care that was provided while an individual was in jail or prison. Do not stop with just one request if the records do not come back to you. And I highly recommend referring patients for legal resources if the care that they received while they were incarcerated was inadequate or contributed to delays or disruptions in their cancer care. When we think about kind of the structure of cancer control in prisons and jails, this is really in the context of both those disparities coming in and then also the fragmentation of care between the community and what's happening within prison and jail systems. And so we do see amplification of health disparities that exist in the community. And that happens because individuals who are at highest risk for poor cancer outcomes are also at highest risk for incarceration. We see major differences between prisons and jails in terms of the structure of screening, diagnosis, and treatment. And that is because the average amount of time that someone spends in a jail in North Carolina is generally between 72 hours and a week. And so that is often not enough time to get records, figure out what needs to be happening, but it is plenty of time to disrupt things. It's also, I think, remarkable the diversity of ways that cancer care is provided while individuals are incarcerated. So in some counties, there is a contract with a public health department. There may be contracts with private clinics, with private corporate contractors that are often referred to as correctional healthcare corporations. Community hospitals also contract with facilities to provide care. And then academic centers, including, I think, all of the major academic centers in North Carolina are the cancer care providers of choice for the jails and prison facilities that are near them. The other piece that I think is very important to mention when we talk about care that happens within prisons and jails is this idea of a dual mission or divided loyalty, which is that prisons and jails were not designed to be healthcare facilities. They function that way, and they function in our country really as the safety net of last resort. But they were not designed to be that. It is definitely the case that while you are incarcerated is actually the only time in the United States that you are constitutionally guaranteed access to health care. But that is a secondary element of what those facilities are doing. And so I want to just give you some examples, thinking about how care gets so difficult while folks are incarcerated. So I'm going to talk a little bit about cervical cancer screening. I'm an OBGYN. I can't not include this slide in basically every talk that I give. So when we look at folks who are entering jails, between maybe a little more than half report being up to date on cervical cancer screening, and nearly half report some history of abnormal PAPs. The map that you're seeing here is actually the county of arrest for each individual who had a dysplasia, an abnormal pap smear in the state prison system. And so this was over like a 10-year period. And so what you can see is that, as we know, there is dysplasia everywhere, and individuals from all over the state come into the criminal legal system. And as a result, because many of them did not have access to routine screening or management of those abnormal results, we see a higher rate of abnormal PAPs during incarceration compared to the community. And we find that health literacy related to cervical cancer screening is very low, even when overall health literacy among our patients and clients is actually fairly high. And so this presents an assortment of challenges as we figure out how to get folks the screening that they need, and also, importantly, not over-screening them, which also happens in many facilities. And we can talk more about that in the Q&A if that is of interest. I want to highlight a couple of really specific examples here. I don't want to read these quotes to you, but we did a research study a couple of years ago where we qualitatively analyzed medical records for individuals who had received care here at UNC and had been incarcerated during their cancer care. And so what is remarkable, in addition to the fact that these are very young patients with GYN cancers, is that in this excerpt from the medical record of this patient, we see that the colposcopy was recommended for this patient, but then she moved. She had a PAP in this state where she had moved to, and then her colposcopy was many months later. And then in another hospital, she then had adenocarcinoma in situ, had a routine screening PAP at a carceral facility who was unaware of her prior diagnosis. That ASCUS PAP prompted referral to a GYN a full month later, and then the request for surgery was ultimately not placed or not approved for another 2 months after that. And so this just highlights the very real challenges that both providers and patients have in navigating all of these systems. This is just again, a medical record excerpt where an individual expressed to the patient expressed to the provider that she was really having difficulty coping with the presence of officers in her room and being chained to the bed, which is a really evocative phrase, and that she feels alone and depressed and wishes that her family could know that she's back in the hospital. These stories are obviously one step removed in that they're documented in the medical record, but they certainly break my heart each time I read them anew. We also found really unfortunate examples about exceptionally poor symptom management. Here's an example of a patient who states she has not been eating well, does not like prison food, and doesn't care if she loses weight. she cannot eat the meat at the facility and needs nutritional drinks. And then another patient who needed several tests for diagnosis and treatment, but refused. And we can also talk about the language we use to describe people declining care, but patient refuses due to inadequate pain control and anxiety about the procedure. We also see individuals who are shackled during their cancer care, which I think is distressing to both patients and providers. And both of these quotes really reflect that individuals are anxious, uncomfortable, and worried about retribution if they express concern. So we're nearly done here. I wanted to highlight in this last piece about improving cancer care for individuals who are incarcerated that improving access to Medicaid, especially now that North Carolina has expanded Medicaid, is really important. There is a federal, basically Medicaid exemption where individuals who are incarcerated cannot use Medicaid while they are incarcerated. And so in many states, they're either Medicaid is either terminated or suspended while individuals are incarcerated. And an increasing number of states have been applying for these 1115 waivers to allow individuals to get back onto Medicaid pre-release so that they can have active Medicaid when they are back in their communities. I don't totally understand how this map was made and that North Carolina appears to be sort of in the middle of this country and not on the coast, but you'll see that we have a pending waiver and are really working hard to get folks re-enrolled in their Medicaid. So I think we're a little close on time. So do you want to do this one?
Sure. We'll respond to as many as we can.
Perfect.
So what is the most useful thing you learned today?
And please just enter your free text.
And we'll take a few of these and then we'll go ahead and move on. And as soon as this is done, it'll be available for you to share your questions. So we won't wait too long on this.
Maybe I will wrap up and then we'll come back to this.
Wrap up and feel free to share something you learned in the Q&A portion as well. Okay, that sounds good.
So wrapping up, I am confident that all of you are already doing much of this, but it always bears repeating to continue to use stigma-free language, practice trauma-informed care, connect with those local and state agencies in the community who are working with returning citizens who need cancer care, to advocate passionately for continuity of care for your patients, and then really support efforts in your community for mass decarceration, as certainly the most straightforward way to address many of these disparities would be to not incarcerate quite so many people. I will take questions and I want to flash up here all the many people that I work with, but then we'll come back to the questions and comments.
Great, and they are already coming in, so
Beautiful.
Thank you to our audience. First one, how easily can a patient get lost in the system?
Exceptionally easily. It is far easier, I think, to get lost than it is to stay found. I certainly have a patient whose cervix cancer I was part of diagnosing many years ago. She had biopsies in multiple facilities by the time she got to me, and no one had sort of put it all together or gotten her to an appointment while she was incarcerated, and I was taking care of her. We were able to get her radiation and chemotherapy completed. She had advanced cervical cancer. And she then would return to the community, which was beautiful, but was entirely lost to care until she was unfortunately reincarcerated several years later, when I was able to reconnect with her and then also reconnect her with cancer care.
Right, thank you. And our poll everywhere is being a little iffy and not wanting to display them. But I am seeing all of the questions, so
Beautiful.
I'll go ahead and keep sharing these. More about circumstances of incarcerated patients and about the prevalence and types of incarceration.
Yeah, so I think the circumstances surrounding incarceration are complicated, and the vast majority are, certainly for folks who are in women's facilities, are related to substance use disorders. And I think when we think about patients who are navigating cancer care during incarceration, those circumstances are really difficult. They have almost always been the result of overlapping adverse social determinants of health, in acting in an interconnected way to where folks weren't able to access prevention, weren't necessarily screened appropriately, and then accessing diagnostic and treatment and surveillance activities is also complicated.
All right, thank you. This is more of a comment. The tragic reality that incarcerated individuals face, you think about the common misfortunes, but you don't really think about how much it affects their health. Thank you.
I think that's a great point.
Another question, is the state, in the state, is the state the insurance payee during the incarcerations?
Yeah, so when individuals are in county jails, it is the county budget. And so that is, I think, a really unfortunate way that these Medicare exemptions shift healthcare costs to much smaller county budgets and away from state and federal budgets. And then when individuals are incarcerated in the state system, the state is the payer at that point.
All right, we've got another comment. Thank you. Excellent presentation. Agreed. Hear, hear. How can we advocate for patients' compassionate release?
That is a great question. I think many individuals who are pursuing compassionate release have a lawyer and can connect you with their lawyer. In addition, you can absolutely reach out to me. My email address will be shown at the end, and I am happy to help facilitate those conversations. And really connect your advocacy with the medical directors and state level leadership within the criminal legal system. Yeah.
All right, here's a comment. I am no longer practicing bedside nursing. I did care for incarcerated patients when I was at the bedside. I found it hard to provide care as I usually provided with a guard in the room and not being very able to understand my patients' needs.
Yeah, you are not alone. I don't know that anybody feels more comfortable providing cancer care while there are armed officers in the room with them. It's just not a natural caring environment. So I appreciate the care that you were able to provide while you were doing that. I'm sure that you made a number of people's lives materially better.
Thank you. A couple of questions that were partial that we didn't quite get all of. Here's another one. Is hospice considered compassionate care for early release?
Generally, I would say yes, that when someone is considered a reasonable referral for hospice care, that is probably a condition for compassionate release, but it is so highly variable based on so many other circumstances. But that is an instance where I would definitely reach out to the leadership within the state prison if that is where the individual is housed, or within the federal facilities if that is where the person is housed. Because at the point when someone is eligible for hospice care, I think we can all agree that their risk of committing additional crimes when they go home is basically zero.
All right. Thank you so much. I know there are probably more questions. I've got 4 or 5 over here, yes, but we are running out of time. So acknowledgments and contact information.
Yes, please don't hesitate to email me.
Thank you so much. And then finally, references. And if you, of course, this is all being recorded, so we don't expect you to read every word of that right now, but that will be available in the recording. We want to say a big thank you to you, Dr. Knittel. This has been a lecture that I've been wanting to have us present for a long time, so
Yeah.
thank you. This is great. We want to thank the people in North Carolina and the state for the University Cancer Research Fund, which funds all that we do, so we're thankful for that. For the UNC Lineberger Comprehensive Cancer Center, we want to thank the team, Venny Obure, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Barbara Walsh for all the hard work that they do for each and every one of these lectures.